Just so excited to be with you today because I have a very special friend with me here. This is Dr. Caldwell Esselstyn. Glad you're with us. We have been friends for more than 12, 13 years. As a matter of fact, I call him just Essie. But that should not take anything away from the profound respect that I have for this gentleman, a man that has challenged the paradigm of cardiological care for heart disease. Tell me, you used to be a well-known surgeon, one of the top surgeons in the country, and then somehow you changed to doing something about heart disease when you were involved with oncology and thyroid surgery. What happened?
Well, actually, as a excellent point, Hans, when I was chairman actually of our breast cancer task force in the late 1970s and the early 80s, I became especially disillusioned with the fact that no matter how many breast operations I was doing for women, I was doing nothing for the next unsuspecting victim. And this led to that global sort of research that I did. It was quite striking to think that in Kenya, breast cancer was something like 20 and 30 times less frequent than in the United States.
20 to 30 times less frequent in Kenya.
And in rural Japan in the 1950s, breast cancer was very infrequently identified. However, as soon as the Japanese women would migrate to the United States, by the second and third generation, they now had the same rate of breast cancer as their Caucasian counterpart. And perhaps even more powerful was when you looked at cancer of the prostate. In the entire nation of Japan, in 1958, how many autopsy deaths were identified for cancer of the prostate? In the entire nation, 18.
18
in the entire nation.
Prostate cancer deaths. Okay, what is it today?
That's a mind-boggling figure. By 1978, 20 years later, they were up to 137. But even that just pales in comparison to the, 28,000 who will die in this country this year from cancer of the prostate. So I made perhaps a decision then, and in hindsight, might not have been entirely correct, but I felt that my bones would long be dust before I could ever get the answers with nutrition and with neoplastic disease, that is to say cancer. And so it seemed to be, it would be a much more expeditious approach to deal with the leading killer of women and men in Western civilization, which was, or is, cardiac disease. And it was so striking that in this global review, there were any number of cultures where virtually cardiovascular disease was non-existent because by heritage and tradition, they were plant-based in their nutrition.
You really think it was related to the plant kind of food diet? You don't think it was the genetic predisposition that people had? Maybe the Japanese picked up the wrong genes as they migrated to America.
Yeah. What happened as soon as the Japanese would migrate to America, they found themselves having the American diseases. Now, it's pretty clear that that genes may load the gun, but lifestyle pulls the trigger. I always use the analogy of, suppose we have that is the analogy of genes. Suppose we have a small a village next to a river. Now, during the flood season, only the very strongest swimmers are going to get across the river. But if we wait to the dry season, when the river is 4 inches deep, everybody gets across safely. And that's really kind of the way it is with heart disease. No matter what your genes, no matter what your stress, if you're not ingesting any of the building blocks for this disease, you cross the river safely.
You know, it's very interesting. People say that it takes about 300 or more years to change the genetics in a society. And we have seen heart disease emerging, coronary artery disease, only after World War I. So the idea that this is genetic, probably not. And if there's a genetic component, you said you have to still trigger it by the lifestyle that you have.
Absolutely.
Yeah. So you began to focus on heart disease because you figured that maybe to really turn the epidemic of breast cancer around might take more time to get things changed. So you started with the idea of doing something about heart disease, maybe not so much preventing, but reversing the disease. Is that right?
Well, the idea was to see if we couldn't halt it. And then there was this. There was actually some experimental data with animals that Dr. Whistler had done in Chicago in the 1970s, where he had been able to, with very, very high fat diets, he'd been able to make these dogs have coronary disease, and then by changing the diet back to something that was not of that magnitude of fat, they were able to reverse this. So that was another really, I have to say, important clue. And then, of course, there's the epidemiology, which we kind of look to, and we talk about. Remember when the Axis powers of Germany invaded the Low Countries and occupied Denmark and Norway during World War II, when they removed all the livestock of these countries, and it was so dramatic to see the sudden reduction in deaths from heart disease and strokes in Norway. When the enemy's living in your backyard, there's your stress.
Yeah.
And although they were kindly Germans.
Oh, yeah, wartime, yeah.
And yet, as soon as we had the cessation of hostilities, back comes the meat, back comes the dairy, back comes the heart attack and stroke. I mean, come on, that is so powerful as data.
I think the rapidity surprised all of us.
Absolutely.
No question. Within a year's time, you
yeah.
could see a decline in coronary disease, and within a couple of years, you could see the ascent again, right?
Emile Picard, who was the pathologist in Belgium, 1946 and 7, at the autopsy table, showing his students, you see these arteries here? During the war years, we didn't see this. And this was only a year after the war had ended. Yeah. Now they're back.
Yeah. So that actually created a lot of hope then within you that maybe we could place people on perhaps a simpler lifestyle, a lifestyle that perhaps was forced upon these countries because of war. So we should perhaps eat a simpler diet?
Yes. I mean, when we say simpler, I think you can still make it exotically complex with these wonderful foods, depending upon your degree of expertise in presentation and blending and so forth of that. I don't mean to ever, but when you think about it, think of the simplest society that you can think of right now that is we hold up as a model as never having heart disease would be the Tarahumara, the three sisters. That's it. Beans, corn, and squash. The three sisters.
Oh, I see. The Tarahumara Indians in northern Mexico.
Yeah.
Three sisters.
Beans, corn, and squash.
Beans, corn. Yeah. Okay.
And
simple foods.
How simple can it get? And yet, look at what athletes these people are.
Tell us about that kickball competition that they have.
6 days in a row.
What do you mean 6 days in a row?
Well, apparently these are 6-day contests. I'm not supporting the celebration that occurs afterwards. However,
but they're really endurance-oriented people living on a simpler diet, foods unprocessed, foods without a mother or a face.
And people will say, well, how would they stand up competing against our athletes that, we have these special Nikes, we have these power bars, we have all these specials. They cross over the border into Colorado and they enter the Pikes Peak race. First, third, look at their feet, sandals. What have they got on the side of their belt? Maybe a little bit of corn. I mean, how wonderful can it get? Yeah. So we have some wonderful models.
So then what you did, you took your lead from some of these experiments, the epidemiology, the different rates of disease in different countries, the emergence of these diseases. As people migrated to other countries, they adapted to the diseases of the host country. And then you began to realize maybe we should try to do this on patients. Now you are at the Cleveland Clinic. You were a surgeon there. You have been there for many, many, many years. So you began now a study sort of on your own by taking inoperable heart disease patients, or what happened?
Well, what occurred was that because of the background and the epidemiology, Ann and I started this ourselves first for a year. being plant-based. Because remember, I grew up on a dairy and Aberdeen Angus beef farm.
I see.
And so this was sort of going against the roots of my upbringing to think that one would stay away from dairy and meat.
So you checked it out first in your own lives. Did it work?
Yeah, it was. Remember, my dad had his first heart attack when he was 43.
43. So you knew you were
Genetically
predisposed somehow, right? Yeah.
So after we'd done that for a year, and we had these results, and our lipids were profoundly falling, I went to cardiology and asked for these 24 patients, and over about the next 18 months, I got them, and 24 was the limit that I could have and still carry out my surgical obligations.
Oh, this was sort of a sideline that became, however, your passion.
What really happened was the challenge was to take these patients who had failed their first or second bypass, they had failed their first or second angioplasty, they were too sick for these procedures, or they had refused, and there were 5 that were told they wouldn't live out the year. And the idea was to see if we couldn't have them really ingesting nothing but this type of plant-based nutrition. And the rock upon which this study was most likely to flounder was lack of patient compliance. Now,
could patients stay with this kind of program?
Exactly.
That was the question, right?
Yeah.
So how did you overcome this? Because that's what you oftentimes hear. Nobody will do this.
Yeah.
How did you do it?
Well, what we have to do is I did not have any kind of a doctorate degree in psychology, but I did have great faith in a mantra that I had used for my cancer patients that I'd learned from Bert Dunphy, who was a surgeon from the West Coast for whom I had great respect. And Bert used to say that patients with cancer are not afraid to suffer. Patients with cancer are not afraid to die. But patients with cancer are afraid of being abandoned by their family or by their physician. So for the first 5 years, I decided I would see every patient in the study every 2 weeks. And then after 5 years, we then stretched it out to every 4 weeks. Now, the usual cardiology relationship with the patient is they'll see the patient maybe once or twice a year. So we got to know each other pretty well. But
plus,
also,
you were living it yourself.
Yes, and also, but therefore, the patients realized that in my eyes, that this was such an important dimension of their care that I was wanting to see them every 2 weeks. And so we did have some nifty compliance. As a matter of fact, I will confess, I am known as a taskmaster. Not as mean as I look, but you know, this was how this was either going to succeed or fail. Now remember, this research started in 1985 before we even knew that the endothelial cell was capable of doing anything. It was just, we were just sort of almost blindly following the epidemiology that we had identified. Right. We subsequently came to understand that the foods that we were asking patients not to ingest, namely the oils, dairy, meat, fish, and chicken, were the foods that we have subsequently come to recognize. Immediately when they pass your lips, these foods injure the magic carpet that is our guardian, that is our life jacket, which is this lining within our blood vessels, where all experts now agree that it's that endothelial lining that is the absolute guardian of our blood vessels.
So